Hi everyone, Dr. Mehta here from Mumbai. In today's Masterclass on fertility, we are going to be discussing only about injectable progesterone. Remember, injectable progesterone is one of the primary modality of luteal phase support in patients who are undergoing their IVF procedure, and that is something which we all know, right? It's important to know that injectable progesterone is available either in an oil-based preparation or it is available in an aqueous based preparation. Now both the things are equally good. Aqueous preparation is going to offer you an advantage of a less painful injection. Oil based injections, as we all know, are much more painful. They need to be given deep inside the gluteal muscle. Actually, progesterone is something which is not water soluble, as a result of which you need oil for it to be absorbed. The typical problem which our patients face following injectable progesterone is that they form lumps at the site of injection, as a result of which the site of injection needs to be either alternate buttock and simultaneously it needs to be shifted in a little. We all have seen patients who have developed sterile abscesses following the progesterone intramuscular injections. One must also remember that though it attains a very good serum concentration, an injectable progesterone actually also undergoes very quick metabolism through the first pass metabolism in the liver, as a result of which the concentration can be variable and may or may not be always sustained. This is very important. Aqueous preparations which are available, which are actually water soluble molecules, they contain cyclodextrin. It's a coating which is actually present around the progesterone. As soon as it enters inside the body, the cyclodextrin disintegrates and progesterone is released. Multiple studies have demonstrated similar serum concentrations, similar endometrial changes through both oil as well as aqueous based progesterone injections. There are certain practical points I think which are important. Remember, these compounds, the injectable progesterone, it should not be stored at more than 30 degrees, especially the aqueous ones. Otherwise, it affects the cyclodextrin, thereby causing pain in the injection and severely reducing the absorption. This is a very important point which people must remember. Second thing, if you were to individualize luteal phase support, we all know that vaginal progesterone administration is as good as injectable. It has been proven without doubt. Vaginal can be in the form of capsules, can be in the form of gels, and they have known to achieve very good endometrial changes. In fact, equivalent changes as compared to injectable progesterone. We must also remember that if we were to do an individualized luteal phase support, usually patients who are obese and patients who are age more than 38-40 are the patients who actually benefit the most when we are giving them injectable progesterones, especially the oil-based progesterones. One of the probable reasons could be that injectable progesterones reduce the uterine contractility, thereby reducing the displacement of the embryo which occurs, especially if you are doing a blastocyst transfer in these women. Another important practical point is that over a period of time, we have realized that we need not give daily injections of injectable progesterone to these patients. An injection which is administered every third or fourth day is also equally effective, as long as you are using one more modality as a support modality. For example, if we are using any oral progesterone, like a synthetic progesterone, along with an oral progesterone, which is usually administered 2 or 3 times in a day, you can supplement it with an injectable progesterone, especially in elderly women and obese women, once every 3 days or once every 4 days. And I think that is going to be a practical point which we've incorporated in our practice for a very long period of time, because we end up treating a lot of women with low AMH, a lot of women who are age more than 40, and we've found that this is something which is very convenient to the patient. It does not warrant a daily injection, so there is no daily pain, and simultaneously it achieves a little good concentration of serum progesterone as and when it is needed. Remember, when you give injectable progesterone, if you were to test the serum progesterone levels, they will usually be in excess of 60, 80, as long as you are giving a daily injection. In fact, measurement of serum progesterone is not recommended following an injectable progesterone. You need not do that. What you should be worried about is the endometrial progesterone. Unfortunately, there is no direct way in which you can measure it. And as a result of which, the common practice of measuring serum progesterone can probably be avoided. Finally, before I conclude, remember, the routine corpus luteum, the natural corpus luteum which develops, produces on an average of 20 to 25 milligrams of progesterone every day, especially in the early secretory phase. That means approximately from the 4th day till the 8th day of ovulation, and that is usually when the blastocyst implantation occurs. The target should be to achieve as close to that as possible as far as the serum progesterone level is concerned, but one can alter their modality of choice. In our next masterclass, we are going to be discussing everything about the progesterone gel and various administrations with molecular changes regarding the progesterone gel. Any further questions you can post in the comments. Me or one of my colleagues will get back as quickly as possible. Thank you so much.